I've been a general practitioner and a university professor for over 20 years, and I work a lot with GPs who work in poor areas, at the bottom end of society and in the front line of the austerity cuts. They're one of the few professional groups with daily experience of how life is lived by less fortunate people in society, and their experience and views are important as part of this debate. Most causes of poor health and thus inequalities in health lie outside the NHS, so we need policies to address that. The NHS deals with the consequences. Poor health is quite difficult to reverse once you've got it, but well-organised and well-resourced healthcare can mitigate the effects. It reduces the severity of problems and slows their progression, delaying their complications. But if that isn't done fairly, based on need, for example, if affluent groups get better care than others, then the NHS can widen social differences and itself become a cause of health inequalities. Most people have a rather simple and happy but exaggerated view of the fairness of the NHS as a healthcare system. Certainly it's fair when it comes to dealing with emergencies. It's often said to be at its best in dealing with emergencies. Nobody's wallet or credit card is checked before deciding if they qualify for emergency treatment. Getting to see a specialist is designed to be fair, but it's not fair in the result because some groups, more affluent, better educated, more assertive, tend to be more successful in accessing what they want from the system. In general practice, which is the first point of contact with the NHS for most people, and where an important aim of care is to keep people out of hospital, we have only a sort of equity whereby all patients have equal access to a GP. Despite steep slopes of need across the social spectrum, with a more than doubling of premature death and complex multimorbidity, that's several problems at the same time. Yet the distribution of GPs and general practice funding per patient doesn't reflect this. It's almost flat, especially in the most deprived half of society. Access to GPs, and people don't tend to know this, it's rationed in the same way that bread, butter, eggs, milk and bacon were rationed in World War II, everyone getting the same. The consequence is that consultations between patients and GPs in poorer areas, where there are more health problems, involve less time, poorer results, and greater GP stress than consultations in more affluent areas. So the needs of patients go unmet, care is less coordinated, complications occur sooner, and patients end up in A&E and hospital beds and eventually die sooner. Yet most people think the NHS is fair. It's a very clear illustration of the difference between what people think the NHS does, what politicians and managers say it does, and what it actually does. What chance have we of addressing the wider factors affecting health when we fail so miserably in addressing this one? If something killed lots of people all at once in one place, there'd be a scandal, but premature death causes private grief, not public outrage. People living in poorer areas die 10 years earlier than in the wealthiest places and spend twice as long in poor health before they die. Spouses become widows or widowers, and children lose their grandparents years earlier than is the norm in wealthy groups. It doesn't just affect small numbers of people at the edge of society. Because the UK has the widest health inequalities in Western Europe, even people in the middle do badly compared with the top. So why no scandal? Why no public and political outrage? First, I think because statistics are people with the tears wiped off. Health inequality is an abstract concept based on comparing statistics from across the social spectrum, while human experience is always based on a particular place in the spectrum, without appreciating what happens elsewhere. We need better descriptions of experience of life in the bottom half of the social spectrum to reinvigorate this issue and re-energize the politicians representing these areas. Second, the unchanging nature of the statistics encourages the view that nothing can be done. Affected groups are also resigned to premature death and morbidity in poor areas. Expectations are low. All that needs to be challenged, and policies need to change. The last 20 years is littered with short-term projects scraping on the surface and stopping too early. They have been decorative rather than reconstructive, a bit like bringing in a painter to make the house look nice, when what you really need is a builder. I have two suggestions. First, given that the UK has the widest health inequalities in Western Europe, we might learn from our European partners how they do so much better. For example, they have fairer distributions of income and they spend much more on healthcare. Second, I think we need to reaffirm the principle of needs-based care as something that the NHS does, not that what it says it does or people think it does. Now that requires a generosity of spirit, the kind shown by our parents and grandparents when the NHS was set up, which understands that only by ensuring that needs-based care is available for everyone can we be confident that it will be available for us and our families if we need it. And if we don't need it, to see that as our good fortune and a blessing for others, something to be celebrated rather than wasted expenditure. As the population gets older, as multimorbidity gets commoner, and inequalities widen, and budgets get ever more tighter, we need to reimagine, reinvigorate and resource the NHS, not as a business making profits for shareholders, not as a public utility with satisfied customers, but as a social institution based on mutuality and trust, sharing risks, pooling resources, and remaining true to the original vision that illness is neither a crime for which people should be punished, nor an indulgence for which they should pay, but a misfortune, the cost of which should be borne by the whole community.